It all starts with the incision. It all starts with the incision and the flap design, okay? And then closure. That's the most critical thing. People say they can suture. Like, it's like the same thing. I say people say they can take out teeth. There's a lot of people that can't take out teeth. There's a lot of people that can't take out sutures. I'm sorry. It's like, I'm not trying to bash anybody. I'm not trying to put anybody down. But unfortunately, it's real world. And this is, people's hands are not all the same, you know? It's just not the same, I guess. It's just different. So, but you have to know how to make good incisions. Why good incisions? Because it all starts with an incision. It's like when you make your incision, right, and you don't make a good incision, it's like a rubber band, right? If you like half cut the rubber band in pieces and you leave behind little tiny strands, that rubber band's not going to split. And then so when you try and open the flap, things start to tear. You start to tear the tissue. You leave behind hamburger meat. What happens is when you go back to close, it just doesn't heal right. So and it's harder to close. It just makes everything should be neat and clean. But if it's not, then it becomes a problem. So incision and flap design is very important, okay? And so when we make horizontal incisions, you can do a crestal or a subcrestal, we call it, or a slight lingual crestal, and I'll tell you why the difference, okay? But and then I talked about a little bit, about the hockey stick buccal incision towards the distal, right? And then when we make any kind of vertical releasing incisions, you want to do it at the line angle, that mesial, that line angle right there. Basically, that's where you want to make the vertical releasing incisions if you're going to do vertical releasing incisions there. So you have what's called the intrasulcular around the tooth here, okay, and then you have the crestal here, basically. So you either a crestal or a subcrestal, basically. I'm not going lingual. You're still on the crest, but you're going more towards the lingual. Why do this? It's a lot of times on the top of the ridge, when patients lose teeth, they lose gums as well too. So gum tissue disappears. They lose keratinized tissue. Keratinized tissue becomes a problem if they don't have it when it comes to implants, because when you have thin gingival tissue around an implant, there's no barrier. You want that thick barrier, but when you don't have it, it becomes a problem. When they brush their teeth around the implant, they'll be like, "Doc, my implant hurts when I brush." It's because they don't have that banding of the keratinized tissue. You need it. It also helps to maintain the biological width around the implant so that you don't get bacteria or debris getting down into the implant, which can cause periimplantitis, perimucoimplantitis, whatever, one or the other, basically. Mucositis, lots of problems, basically. So it's really important. And then so around the tooth, you can do either completely around the tooth and cut the papilla, okay? Or you can do a papillary saving incision where you don't cut the papilla. When to or when not to, basically, right? If the space is too narrow, then you have to cut the tooth because you can't make a tiny little incision and expect everything to place and close, basically. So when you have a big enough space though, and you have healthy gums, your gums are healthy here and here, there's no periodontal issues, why cut the papilla? Why try and induce recession? You know what I mean? So if you have healthy gums, and you have enough space, then you do a papillary saving incision, basically. That's what it's called for. If the space is too narrow, or they have periodontal issues, then I would go all the way to the papilla and cut it open. And I'll show you in one of my video cases. I'm doing SRP on the patient with after the incision, whatever, after the flap, basically, because of perio issues. But anyway, so crestal incision, okay, so. Always the most ideal crestal incision, okay? That's the incision that we always want to make on top of the ridge there, okay? It helps to bring your flap back for closure at the end, and they heal better. Patients heal better all the time with the crestal incision. Less tension. And then papillary saving incision, you want to stay a millimeter away from the tooth there, so. And then also lingual crestal incision is where you're trying to bring more of the keratinized tissue to the buccal, basically. So that's when that's needed, basically. The tissue becomes a little bit thinner towards the lingual, so you have to be careful. So, and you don't want to tear anything as far as things go. So, but you can add more keratinized tissue to the buccal with the healing element afterwards. So, and the vertical releasing incisions always at the line angle, okay? Always at the line, not here, okay? Not here or here, basically. That's where you want it. So that's where you make your vertical releasing incisions for better blood supply. Always have a wide base too, because it's all about blood supply on your flap. So if you don't have good blood supply, you don't heal right. So. The incision should be very deliberate. When I say deliberate, you have to make a very clean cut. So when you put that blade into the tissue, right? You want to make sure that you hit the bone and you're scoring the bone type of incision. Okay, your blade will dole out after like 1 or 2 cuts, basically, because they're very sharp. Number one, and then I want you to when you make a cut, I want you to be very deliberate and actually cut all the way down, because I don't want you to leave behind any fibers. Because when you leave behind fibers, and so if you make your cut and you're like very gentle, right? And you don't cut all the way down and you start scraping and then you come all the way through. And so you have all these fibers below. that are still attached, right? And you go to lay the flap, and so you don't have a full thickness flap number one, you have a partial thickness flap. So now you're starting to get hamburger meat, whatever, which is not good. So it all starts with the incision. This is where incision is so important, basically. And then there's the intrasulcular incision, basically using like a 15 or 12, usually a 15 blade, basically, if you're gonna do that. And then, so you always want to make sure that, when you lay the flap, you maintain a wide base. You want to maintain good blood flow. You don't want to have any tear, basically. You want a clean cut, clean flap, basically. Because when you have tears, when you go to close anybody up later on, it's hard to get primary closure. It's very, very hard to get primary closure. And primary closure is key to getting good healing. Body heals pretty well, but if you help it, it makes a difference. You got to help it to make a difference. And this is one of the ways to alleviate that or prevent that. There's different types of flaps. There's like the semi-lunar flap. There's the trapezoid flap. There's a triangular flap. And there's also the envelope flap. I like the envelope flap because you don't have to release, there's no vertical leg. But the problem is the tissue becomes tight, right? And so because the tissue is tight, you can tear more if you try and keep going, you know what I mean? When you try and pull it out or whatever. But so you have to be careful with the envelope flap. But as I said, the more you do like this, it's more traumatic. So there's more pain associated with the procedure. The less you do, there's less pain. So this is one of the benefits of an envelope flap, but it's more technique sensitive as far as things go. And then when you guys make your cut, you should hold your scalpel handle in a writing pen grip, okay? And you want to cut always towards you, not away from you, okay? You don't and you don't want to use the edge of the blade. You're using this part of the blade to cut, not the tip, not the very tip. Okay? And then you always want to cut towards you, not away from you, because you can slip if you try and cut away from you. So you're always holding and then you're cutting towards you, okay? You should have a good fulcrum base as you're cutting. And then when you guys go to suture or whatever, if you're holding the needle, you never want to hold the needle at the very tip like this, because you can damage this area where the needle and the suture is actually connected to. So you always want to be a little bit away from the swatch of the needle, we call it, okay? And then when we make our penetrations, the bites that we call it, right? You want to be at right angles. Your needle should be driving into the tissue at right angles, and not so that you're grabbing enough tissue as you're going in. And then you always want to follow the curvature. We usually use a reverse curve, C-shaped curve needle or whatever, and so you just want to follow the curvature of the needle there, basically. And then you should be about 2 millimeters away from your incision, basically, or 2 or 3 millimeters away from your incision. Suturing is all about vectors, So you want to grab the tissue, like if you grab it here, you always want to grab it here too. You don't want to be here, and then you don't want to be all the way out here. That's not good. That's not good. So you always want to maintain that if you can, okay? And then when you have attached gingival, if you're having a vertical releasing flap, you want to go from the free side to the attached side. The reason why is if you go from here, you tend to tear this basically as your needle's driving. But it's not always the case. Sometimes you can actually, if the space is tight, you might have to go from the attached side and be real careful. I don't suggest using needle holders either, because remember, when you try and unclick the needle as it's held, when you're going to the attached side, you tend to tear the tissue because it's like you're trying to manipulate that needle holder to unclick it, and then so Castro Viejos are very good for those areas. But yeah, this is very hard. This is very hard. If you've done this before, you know what I'm talking about. Because tissue, especially on patients that have thin tissue or anything like that, this tissue is frail and things will tear, and you keep tearing the tissue, and then this is where difficulty arises, basically. And then you should start from thinner tissue to thicker tissue when you guys make your, as far as suturing goes, not from thick to thin, the other way around. And you always want to go from shallow to high, not from the other way around, because it just helps to bring it up basically to better closure. And the depth at which it should be greater than the distance of the incision, basically. Okay, so you should be deep enough. That's what it means. Okay, but it just depends on the flap as far as the flap goes. So sometimes if it's a flap, you're not concerned. That's if you're actually going in not really a flap of tissue, but. And then you don't want your knots or tight to be too tight where you're blanching the tissue. Like you don't want to be super tight, because what happens is you get necrosis. If you blanch the tissue, you get necrosis. That's what happens basically if it's too tight. So you should be there's an ideal tightness, we call it. You don't want to be loose either, where it's flappy either, but you want to be somewhat pretty decently tight that it's not blanching the tissue. So, and then the knot should not be on top of the incision line. You should kind of move it away from the incision line because that helps to promote healing. Okay. And And then our inter suture distance should be about 3 to 4 millimeters. You know, if you're doing interrupted sutures or whatnot, there basically. Simple interrupted sutures. So how to make a simple interrupted suture? Okay. So we take a bite and we bring it over, take another bite, right? And it's pretty simple, right? And then you tie, right? So you tie that knot, right? And you keep doing the same thing. Same thing, same thing. It's like multiple sutures, right? So my daughter, right after Thanksgiving, she's 14. She was down in the basement. So I live in Indy, so we have a basement. Here, I know you guys don't have basements here, but yeah, so we have a basement. So I have a gym in my basement. So this is one of the luxuries of living in Indiana. So we have a big, you know, it's like our houses are bigger because it's cheaper. And I have a gym. I'm not trying to brag, but I'm just saying I have a gym. So my daughter went downstairs. She said she's going to exercise. So she got all dressed up. She was down exercising. I guess she was using the ab roller thing, whatever. And I have a gym where it's matted, but she was on the hardwood floor area. I guess she was doing that, and she slipped, and she fell, and she cut her chin open, like on the bottom here. So we had to go to the ER. I mean, technically, I guess I could have sutured her up, you know, but anyway, so I haven't gotten the bill yet, so it's going to be probably a couple grand for that, even with insurance, I don't know. But anyway, so they placed like 4 interrupted sutures, basically, on her, you know. So they use just plain gut sutures, I think. She used plain gut sutures, and so 4 interrupted sutures like this. So it's pretty straightforward. This is what we do day in, day out, basically. Interrupted sutures, so. And then there's the horizontal mattress sutures. This is very important for like when you do GBRs. Horizontal mattress sutures it's effective. What it does is it helps to kind of put less tension on top of the ridge when you create the suture, basically. So remember, we talked about like having tension-free closure, we say all the time, but there's no such thing as tension-free closure because there has to be tension somewhere. Because when you open things up, you add implant, bone, all this stuff, things are gonna get loose, right? I mean, it's gonna be tight because you're trying to close this back up again, right? And even though you release the tissue and you close this up, it's gonna be tight, right? But we're trying to relieve the tension right here at the very top, right? And so when you create this horizontal mattress suture, the tension comes to below the incision line, right? So more of the tension is here. So when you put the interrupted sutures on top, there's less tension on the very top, where the tissue is very, very frail, I guess you could say. It's more delicate. Now, I'll show you how this is done. But this also is a good suturing technique to stabilize your membrane when you do GBRs. And I'll show you that too. But anyways, this is a very good suturing technique. So how to make a horizontal mattress suture, okay? So normally, like I would bite further away, okay? But this is just a diagram. So normally we bite further away because you want to be below this area. You don't want to be near the incision line. You want to be below, further below, like maybe 4 or 5 millimeters below, okay? I would take a bite here, come out, same thing, bite over here, basically come out, okay? And you come across horizontally, right? Take the same thing. You take the bite 4 or 5 millimeters across, come over the ridge, and from the inside out again, okay? Same thing, 4 or 5 millimeters outside, you come out through. So it's horizontal here and here, basically. That's what it means. So the strings are going above the ridge. So it's from either the buccal or lingual, right? You're coming here, out above the ridge, down out to the flap, basically, right? And you're coming horizontally, either direction or whatever, right? And then you're coming from buccal to lingual over the ridge, from inside the flap, out towards the lingual, whatever, buccal, whatever, right? And then we're making our tie. That's how we're making a tie. So same thing. That's how that picture is showing, right? That should kind of give you a pretty clear picture of what I'm talking about, right? And then you tie. So when you tie, this is what happens. We call it, so when you tie, this is what happens. It starts to do this, basically. Tissue comes together like this. And the vertical mattress sutures is exactly the same thing, but the direction is in the vertical direction here. Instead of horizontal direction, it's in the vertical direction. Okay? So there's vertical sutures and there's horizontal sutures. So, 물병 한번 주겠어요? Are we ready? Go? Good? Okay, welcome back. I hope you guys had a good lunch. Well, we did here. I don't know about you guys at home or wherever you guys are at. So back to our vertical mattress sutures, okay? It's pretty much the same as our, what did I do with my pointer? Did I leave it on the table? So back to our vertical mattress sutures. It's pretty much the same as our horizontal mattress sutures, but the vectors are in the vertical direction instead of in the horizontal direction. So it's almost similar, very similar to the horizontal mattress sutures. They are mainly used for, like if you're doing connective tissue graft in the palate, we take those usually for those type of vectors. And so that's what they're used for. And then figure 8 sutures, these are great for extraction sockets. I use this often, very often after extractions. They help to create nice closure after an extraction site. So it's very simple, horizontal. So you do the same bite and pass through like a simple interrupt the sutures, and then but you come across again to like the mesial distal of the extraction socket, let's just say, and then you go through again once again like an interrupt the suture, and then you just create a tie when you're done. So it creates that X on top. So it's very simple. It's not very complicated at all. But these are great. These are great for post extraction, like on a premolar site. They're really perfect. So sometimes on a molar site after an extraction, if I'm doing a bone graft, I use a figure 8 within a figure 8, and then I tie, basically. So the 2 wide figure 8s, because the span is pretty big, right? So if you put an X and just put an X, it's like too big, it's too wide. So I go figure 8 to the out, like mesial distal or whatever of the tooth, like in between the distal of the tooth and the mesial of this tooth, whatever. And then I do another figure 8 in the middle of it too, and then I tie. So it's like a figure 8 and figure 8 within a figure 8, basically. So they're very useful. And then crisscross sutures is almost like a figure 8, but the directions are a little bit different. Okay, the way how you go through. So from here, like here, for instance, you're doing like it's not a horizontal mattress, but you're going in the horizontal direction. You're going in the horizontal direction, and then you come through on the opposite side of the incision, and you do the horizontal vector as well too. Once again, and then you just create your tie. So the X actually gets underneath the flap, so you don't see the X. Oh, wait. Oh, this one you see the X. I'm sorry. This is the hidden X. Okay. So this one's a little different. So it's almost the same where the X is hidden underneath the flap. So this helps to prevent the gathering of the keratinized tissue. If you're trying to help keratinized tissue grow more, this is one way to do it. So this one you actually cross from here horizontally, but you come across in a diagonal fashion to the other side of the incision, the flap. And then you go back to here, across, and then go diagonally again to the other side. And then so you get the hidden X underneath. So the X becomes underneath the flap. And then so this is like the horizontal and a mattress suture together. So internal mattress, either internal vertical mattress or internal horizontal mattress. These are great for like GBRs. We use these all the time for GBRs. This is the best because what happens is when you create that internal mattress suture, the flap looks like this. It comes together down here at the base. And so you get what's called a praying hand, we call it. So the flap looks like this. So this is tension free up here. The tension gets down here on the base. And so, and then you put interrupters on top. So these are great. And this is also great for like fixating the membrane. So we start with like this is a vertical internal mattress in this manner here, in this picture. So you start with the vertical mattress basically to stabilize. And then this is going within the tissue here. But you can come all the way out. So we use it within the tissue. If you have a membrane, you're trying to stabilize the membrane, I use the interperiosteum basically when I'm doing this type of suture technique basically. But so you put an internal mattress suture, and so your tissue gets tight. Like when you tie it, it becomes like this basically, and then you put an interrupter on top. And then continuous interlocking, continuous sutures are really good too. I don't use regular continuous sutures. I use continuous interlocking sutures, and the reason why is the vectors of this kind of is more diagonal to the cut, to the incision, but when you have continuous locking, it kind of straightens the vectors out. It's more straight. I use these all the time for lower 17 or 32, or even just lower extractions, whatever. I use this all the time. I think it's a fantastic way to get primary closure on lower areas, basically, because tissue has give, the flap has give, basically, and so when you use this, it creates a nice tight seal. It creates a pretty decent seal in the back areas. So or even if we're doing like a full mouth extraction case or whatever, I do continuous interlocking sutures for closure. These are really, really good. And then, so this is what I was talking to you about earlier, about how to stabilize the membrane, basically. So you place the implant, you place some bone graft, you place the membrane, you did some GBR, right? And then so you can place a mattress suture, you can place a horizontal mattress suture. You can do it where it's crisscross, or you can do it, whatever direction. The way so you're doing a horizontal mattress suture where you come like from here, come across. So you're biting within the tissue here, basically, coming across and then coming out, and then you're tying, basically. That's all you're doing. You usually on the uppers, you want to start on the palate because the tissue's thick. The palate tissue is very thick, so you start on the palate so that you can tighten that sucker up pretty good. And what it does is this membrane, it kind of moves around everywhere right now, right? But once this is on there, the membrane gets tacked in. It stays still, basically. And then you can put another horizontal mattress suture where you come through here, and then get the flap closed. And that way the flap becomes nice tight again, and then you can do interlocking or whatever sutures you want on top there to close that up. So these are really great for GBR cases. And then to tack, it's like a tacking suture. So if you pull on the cheek and the flap or whatever the incision, the surgical site moves around a lot, this is contingent upon the fact that you did like a split thickness graft. Like this is more for connective tissue graft and stuff like that. So that because it's like the periosteum is still intact, so you drive the needle through the periosteum to attach the tissue so that it doesn't move on you because stability is very important after grafting procedures. Because if you pull the cheek and you can move that, then it's like it'll fail. The graft procedure will fail. So this is to help for to stabilize the tissue from moving if you pull on it or anything like that. And then this is like if you lay a flap and you don't want it in the way, and you're putting a guide or whatever, you can just put an interrupted suture to help retract the tissue for you, so you don't have to keep retracting it. So that you can use like silk for this type of, because you're just gonna cut and throw it away, But yeah, but like regular, so when you close up, you don't really want to be using silk for regular like closures like these or whatever, because silk tends to build up a lot of plaque, and so that's the reason why I don't like silk. So Vicryl sutures or like PTFE sutures, those are better. So how to make a knot, okay? So we call it surgeon's knot. This is the most classic knot. I use this day in, day out. So it's a 2-turn clockwise direction, 1-turn counterclockwise direction, and then 1-turn clockwise direction, basically. So in order for you to have a nice, tight, like when you first make your knot, your line here should line up, basically. That should try to get lined up, not crisscross if you can. Because that way, when you pull with the hemostat, whatever your needle driver is, right? When you pull on it and you have the tail, if you let go of the tail shouldn't follow. It should hold. If you pull really hard, the tail will follow, but when you hold on it, the tail should stay. That way, when you make your counterclockwise turn and you grab the other end of the tail and you tie it, it stays tight, basically. Versus if you pull on it and the tail's following you, then it's not going to hold. And your flap closure is going to be like loose, basically. So that's a simple how to make a surgeon's knot. And then you have a square knot, which is just 1 turn clockwise, 1 turn counterclockwise, 1 turn clockwise, basically. So one of the main differences is just 2 1 1 versus 1 1 1, basically. That's the only difference. So square knot. And then when you go to remove, just cut. I mean, this is pretty simple, basic. I mean, I don't think this requires any kind of explanation about removing sutures. Just make sure you cut the knot. You know what I mean? You cut the knot and then you pull the other side where the knot is not present. So, suturing is just to hold the tissue for a few days. That's it, mainly. So it's not really to like keep everything super tightly closed, and then you're relying on the body's healing process to reattach. So after any kind of closure of any sort, I always say put pressure on the wound, because remember, you've laid this flap, you relayed the flap, and so there's what's called dead space. Even though you put them back together, there's what's called dead space, like it's airspace, basically. So you want to try and get rid of it. So take a piece of wet gauze or gauze, just put it there and put pressure on there. Just put it all down, tack it all down so that you get nice. And also, if you did any kind of GBR or bone graft procedures, you want to make sure you put pressure on the bone to make sure that the bone actually is nicely condensed to the actual bone, whatever that's there. So there's no voids or anything like that. So this is more about surgical cases, okay? So I'm going to talk about a little bit of bone grafting first, and then a couple of implant surgery. So